Hello, everyone, and welcome to today's webinar hosted by the International Society for the Prevention of Child Abuse and Neglect. In today's webinar, Dr. Tracy Afifi, lead author of the 2017 Article of the Year for Child Abuse and Neglect, will share insights and key findings from her award-winning article entitled Spanking and Adult Mental Health Impairment, the Case for the Designation of Spanking as an Adverse Childhood Experience. Afifi and her colleagues found that spanking was empirically similar to physical and emotional abuse, indicating that these experiences are highly correlated and reflect a similar underlying process. They concluded, therefore, that spanking should be considered an adverse childhood experience and addressed in efforts to prevent violence. Right now, I have everyone on mute to avoid background noise. We welcome you to enter your questions and comments for Dr. Afifi in the chat box throughout the presentation. She will answer any questions at the end as time permits. Dr. Tracy Afifi is an associate professor in the departments of Community Health Science and Psychiatry at the University of Manitoba, and a research scientist at the Children's Hospital Research Institute of Manitoba. She is also an associate editor of Child Abuse and Neglect. Her primary research interests are child maltreatment and mental health, with a focus on resilience, intervention, and prevention. A prolific published author and conference presenter, Dr. Afifi is also an inducted college member of the Royal Society of Canada and was the 2018 recipient of the Royal Mock Gainsland Prize for Mental Health Research. Tracy, we thank you so much for being with us today and sharing your insights. Now I will turn it over to you. One moment, please.
Great. Hi, everyone. Thank you for inviting me and having me today to present on our research findings. So today, as mentioned, I'm going to be talking a lot about spanking and how it could be considered an adverse childhood experience, and how it's associated with adult mental health impairment, as published in our 2017 article in Child Abuse and Neglect. But first, I want to just acknowledge many of the people who have worked with me in this area, specifically on adverse childhood experience and ACEs over the last number of years. And I would also like to acknowledge many different sources of funding that has been used for a number of ACEs and child maltreatment studies, as well as acknowledge the CDC, the Center for Disease Control and Prevention, for providing access to the article that we'll be talking a little bit about later on in the talk today. So with regard to objectives, instead of just talking about the research article, I thought it'd be important to also review a little bit of the history of the ACEs field and talk a little bit what it means when we say ACEs and what is an adverse childhood experience, and also to review what's currently known about ACEs. And then once we understand what a little bit about the ACEs field, to start thinking about what do we mean by what is an ACE and how should we define ACE, especially in the context that we're in this research thinking about whether or not spanking should be considered an adverse childhood experience, and whether that's something we should be doing for reconsidering the ACEs definition. And then we'll review the article in more detail that we published in Child Abuse and Neglect on spanking and ACEs. Okay, so we'll talk a little bit today, and then as mentioned, we'll have time at the end for any questions and further discussion. So first of all, what is an adverse childhood experience, or what is an ACE? So if we were live and interactive, I would ask people how many people know of this term ACE. And some people do and some people don't. But the term adverse childhood experience is something that's been used in the literature for decades. And it's really only been in the last 20 years that it's been used more consistently as an adverse childhood experience. So in the past, people would use the term, and it could mean a number of things. It could be anything that's considered to be an adverse event for children. But over the last 20 years, we've started to use ACE. And what does that mean? And what does it look like? So what is an ACE? So there's typically 10 adverse childhood experiences when people use this term ACE. And 5 of them are child maltreatment. So they're either abuse or neglect. So physical abuse, emotional abuse, sexual abuse, and also physical neglect and emotional neglect. And then there's 5 types of household dysfunction, or sometimes this is referred to now as household challenges. And that's whether or not a parent or person in your home, an adult in your home, had mental illness, whether they were incarcerated, whether or not you witnessed your mother being treated violently, whether there's someone in your home with substance abuse problems, and whether or not your parents divorced while you were in childhood. So this is an image from the CDC to describe the ACEs, and the CDC has done a lot of work, especially in the last 10 years or more, really understanding and keeping surveillance of ACEs in the United States. So when people use the term ACE, they're typically referring to these 10 ACEs that has sort of shaped the ACEs field. But often in research and in more mainstream media, when we talk about ACEs, we don't often look at those individual ACEs in a lot of detail. Some studies will, but a lot of studies will focus mainly on your ACE score. So what is an ACE score? So an ACE score is simply, if we go back to this list, adding up how many of these events actually happen to you. So it can be a real simple tool where it's listing these adverse childhood experiences, and an individual can go through and say whether or not they had that experience, yes or no, and then they count those experiences up. So if there are 10 ACEs, you may have 0 to 10 of these ACEs. And in the media and in research, often that score is used rather than looking at the individual types. So if we look at this, you could even, if you haven't already done so, if you're not experienced with the ACEs field, you might look at this and sort of scan through and sort of very simply calculate what your ACE score might be. So if we think about that, you can see someone might have a score of 3, and that might mean that their parents divorced when they were children. Their mother may have had depression, and their father may have had problems with alcohol. So that's three of the ACEs, so that would be a score of 3. Another person could have the same score of 3, but their experience might have been that they were physically abused, emotionally abused, and sexually abused. So you can see when we use the ACE score, we might have the same score, but individuals can have completely different experiences. And that's something to think about when we think about the ACEs tools and how we conceptualize what this score actually means. So this ACE score has sort of become more mainstream. This is from the National Public Radio website, and it's these tools and quizzes are online in a number of different places where you simply go through and take the quiz, and it's basically just adding up those experiences and getting those scores. Some websites will also have a resilience score as well, so you can calculate how many adverse experiences you have, but there's also an equivalently short tool to determine what your resilience score might be as well. So with regard to the history of the ACEs field, as I mentioned, there's a large literature on childhood adversity and maltreatment, so it goes back more than 2 decades. But it was really in 1998 when the first ACEs study was published, and that was published by Felitti and colleagues that looked at that used the term adverse childhood experience and then used ACEs as the abbreviated form. And since that time, over time, this term ACEs have become more consistently used in the literature, although there's still a lot of inconsistencies in how we conceptualize ACEs in studies as well, and I'll talk about that in a few minutes. But a little bit more about the history. So Dr. Felitti is a medical doctor in California. He's an internist, and he was running weight loss clinics, and he was noticing that people were being successful with weight loss, yet still dropping out of their weight loss program. So he did a lot of thinking and some research in this area, and in the early 90s conducted a case control study where he compared obese adults to non-obese adults. And what he found was among the obese adults, he found that they were more likely to have experiences such as child physical abuse, sexual abuse, parental loss, and parental alcohol problems. And then from more of a qualitative perspective, was able to determine that when individuals who had had a sexual abuse history and who had were obese, when they would start to lose the weight, they began to have unwanted sexual attention, and therefore they felt more comfortable if they put the weight back on, so that they didn't bring this attention to themselves. So it was almost like the weight served as some kind of protection. And others may have used the excessive food intake as a negative coping strategy to deal with emotional distress. So started to really learn that these physical health conditions may be related to things that were happening in the individual's childhood. So that led to the first ACEs study that was published in the American Journal of Preventive Medicine in 1998. And this study was the first ACEs study that was published. And you can see I wrote the citations down there. It's over 4,000, approaching 5,000 citations. That was, I believe, last week, so it will be even higher than that, I'm sure, today. This is the most highly cited ACEs study to date, and likely will always be the most highly cited ACEs study. It's one of those studies that sort of gets cited in all ACEs research. Because it is the first study to kind of really conceptualize this idea of adverse childhood experiences and looking at health conditions. So this study looked at how these conditions are related to a number of different health outcomes, both mental and physical health outcomes. So we'll review that a little bit. Interestingly, this isn't a nationally representative sample. So a lot of those highly cited papers to date would be those that come from nationally representative samples, but this is not a representative sample. It's actually a clinical sample. It's a sample of adults with a very wide age range, mostly white adults who lived in California, and adults who had health insurance. So it's, again, not representative of the population. The data were collected in 2 waves from 1995 to 1997, and they started with 17,000 adults, and they would come to the clinic for their clinical visits, and then after that, they were mailed out a family health history questionnaire that they completed in their home, in which they would then mail back to the researchers. So as I mentioned, this was done in 2 waves. So the original waves of the ACEs study included 7 adverse childhood experiences. So that was physical abuse, sexual abuse, emotional abuse, violence against a mother, a household member having problems with substances, household member having problems with mental illness, and incarceration of a household member. Then 2 years later, they did the second wave of data collection, and in that data collection, they asked about 3 additional ACEs. So they added physical neglect, emotional neglect, and parental separation or divorce. So these 10, which are what was depicted in that earlier CDC image, are typically were the 10 ACEs that were included in the original study. And many papers were published from that original data, and we'll look at some of those papers. And so these were the original 10 ACEs, and really to date, when we think of the ACEs field, and still when we do those ACEs score, it's still these 10 ACEs 20 years later. So the field hasn't really evolved from these 10 ACEs. So back to that original 1998 study, as I mentioned before, there were a number of physical and mental health outcomes that were looked at in the paper, and remarkably, the relationships between having experienced an adverse childhood experience and these outcomes were significant across the board. So the findings indicated that if an individual reported that they'd experienced ACEs as a child, they had increased odds of currently being a smoker, they had higher BMI, they were more likely to report no physical activity, more likely to report having depressed mood, having had attempted suicide, more likely to have problems with alcohol and drugs, more likely to report large numbers of sexual partners, more likely to have had a sexually transmitted infection, more likely to experience heart disease, cancer, stroke, chronic bronchitis, emphysema, and diabetes. So there are many, many outcomes in the study, and they were all significant across the board, and it was really an important study to link adverse childhood experience with health, both mental health and physical health. So the number of ACEs studies has increased over the past 2 decades. In the first years after that first study, the main studies were really from this group who were using the original ACEs data and looking at a number of different outcomes. So a lot of studies did happen in those first 5 years or more after that, but it was really mostly from this group and with this original data. And then after that, other people started to collect their own data using these ACEs. And the number of ACEs grew over the last 2 decades. And with that, that meant that the ACEs were being examined in different populations, sometimes in different clinical samples, sometimes in representative samples, but you would start to see the field move away from just this one sample to looking at ACEs in different populations. And as you can see here, we've done a somewhat formal / informal scope of the literature. And what you can see is that it was really around maybe 2012, 13, 14 that these ACEs studies really started to increase in the literature. And then from that to current day, you can see these large stepwise increases in the number of ACEs articles that are published every year. So this is a large and growing field. And as an associate editor of child abuse and neglect, I can say that we see a lot more ACEs papers being submitted to our journal currently than we had in the past. So it's a very interesting time to be part of the ACEs field for sure. So what is currently known about ACEs? Well, we know that ACEs are highly common and prevalent in North America. There are ACEs studies that from a global perspective, so there are a number of other countries where we do have ACEs data from. A lot of those studies actually use an ACE IQ, so the international questionnaire, so the ACEs are a little bit different in those studies. So there are global studies, however, the vast majority of the research to date has been published in North America and actually mostly in the United States. So some studies in Canada, that's growing over the last number of years, but still most of this data is actually coming from the United States. What we know is that ACEs are very common. So when we look at a majority of adults who are retrospectively reporting about their childhood experiences, if we have one or more ACEs, the prevalence can be anywhere from 52 to 67%. And of course, this is sort of pooling across different studies. So this is not just in one sample, but in a number of samples over the number of years. 2 or more ACEs can be reported as high as 25 to 42%, and 4 or more ACEs, 6 to 16%. So you can see they are quite prevalent in the United States and in North America. This is just an example using data from the Behavioral Risk Factor Surveillance System. So this is data from the CDC. This is more representative samples from the United States, and this particular data is from 2010, so a little bit newer than the 1998 data. But what you can see here is even when we use more representative samples, the number of people reporting adverse childhood experiences is quite high. And when we look at this, actually, here, almost 60% of respondents from the 2010 wave of data are reporting they've experienced one or more adverse childhood experiences. So quite high. What else do we know about ACEs? So looking at a cross-section of the literature, we know that ACEs are associated with poor mental health outcomes. And so that includes mood disorders, anxiety disorders, PTSD, eating disorders, antisocial personality disorders, substance use, suicidal ideation, plans and attempts. We also know that ACEs are associated with poor physical health outcomes. So some studies have looked at liver disease, heart disease, COPD, diabetes, fibromyalgia, autoimmune disorders, asthma, headaches, cancer, obesity, and pain. So we know that it's associated with both mental and physical health outcomes. Beyond mental and physical health outcomes, we also have seen that ACEs are associated with poor sexual health behaviors. So that includes being both a victim or a perpetrator of violence in your intimate relationships when in adulthood. It's also associated with unwanted pregnancy, sexual transmitted diseases or infections, and having a large number of partners, which we noted in some of the earlier ACEs studies using the original data. And then similarly, those who have experienced ACEs in childhood are also more likely to experience violence across the lifespan, so in adulthood, and this includes physical violence, but it also includes sexual violence. So that's sort of a cross-section of the current state of knowledge with regard to ACEs and a number of outcomes, both health and social outcomes. Over the last number of years, ACEs have become mainstream in the media, and I think it sort of started around 2014 with this really wonderful talk by Nadine Burke-Harris. It's a TED Talk that now currently has 5 million views, so I'm sure a number of you have seen this talk, and if not, it's a good one to go and sort of get a very moving speech on childhood trauma and how it affects health across the lifespan. So this gained momentum in the general media. Also last year, Oprah did an episode of 60 Minutes talking about treating childhood trauma, where she talks a lot about adverse childhood experiences and how it impacts someone's life and how to recover from that. So it's in the media more often, and that's something that is helping, I think, to grow the field. So to review, going back to thinking about our current definitions of ACEs, this is the 10 ACEs that we have here. Now, a number of studies have included all 10 ACEs. Some studies will include some of the ACEs, but not all 10, for a number of reasons, whether or not they have data on all ACEs. Other studies will include some of these ACEs and then add different adverse childhood experiences in. And so, as I say, when over the last 20 years this term has been used more consistently, that's true. But what's also true is that there are still inconsistencies in how it's used in terms of how we think about and what we define as an adverse childhood experience. So that brings us to the question of whether or not we should consider expanding the definition of ACEs. So again, when you think about those 10 ACEs on that list, it's not a comprehensive list, and it wasn't intended to be a comprehensive list when it was first put together. But when we think about that, it's important to think about the theoretical or empirical evidence for having this construct with 10 ACEs that's been used in the field for decades. And interestingly, there hasn't been any measurement rigor or any real development of the ACEs tools over the last 2 decades. And this is especially interesting because there's been huge advances in the child maltreatment literature with regard to how we measure child maltreatment, so specifically abuse and neglect. And that's evolved over the last number of years. A lot of new tools have been developed and have been tested for their methodological and measurement rigor, but that hasn't really happened in the ACEs field. And these 10 ACEs kind of came together, and there wasn't a lot of innovation or development of those tools, but it's remained in the literature, and it's remained in research as well. So one reason for the strong uptake of these 10 ACEs, despite the lack of measurement rigor, might be that such a tool is freely available. So you can go online and you can get a checklist freely available. It's a really short tool, and it's easy to administer. So if we are interested in using this in a clinical setting, or we're interested in using this in a research setting, it's easy to use and it's fast. So, and it's free. And those are three really important things especially for researchers. So that might be one reason why this has continued to be very popular in the literature. And as I mentioned, it's not a complete list, but it wasn't intended to be such. So if I were to ask people to think about what else would you consider an adverse childhood experience, I'm sure you could double this list to 20 within minutes or seconds. We could probably have a quick session where the list becomes 100 or 1,000 experiences. So it's not to say that these are the only adverse childhood experiences. And expanding the list, then we have to question what would the reason for expanding the list would be. It would then not be a short list, not be easy to administer. So we're sort of taking away those aspects. The other thing to consider is if I challenge you to think of global perspectives, adverse childhood experiences in one country may be very different than in another country. So that's an interesting thing to think about and complicates the list. So we are, I think, at a point in the field where we should be thinking about the definition of ACEs and contemplating whether or not we should be expanding the list. And it's not just an exercise to make it really long, but to think about updating it, being innovative. But then when we do that, we need to think about how do we add to this list using theory. So we want to be theoretically informed. We might want to be using previous research to guide our decision making. And then we want to follow that up with empirical examinations. So that's part of the field that hasn't really been put forward, is looking at how these types of ACEs and other ACEs hang together in terms of empirical evidence. So changing the definition and reconceptualizing ACEs would not be a simple task. And as I mentioned, if we think about the global perspective, it makes it even more complicated. But I think researchers should be encouraged to think innovatively to try and advance the field using empirical evidence that's theoretically informed. So not just simply sitting together and brainstorming a list, but how do these things theoretically, are they informed, and then let's look at them empirically. So do some research and see if they actually support that. So recent recommendations have been done using empirical evidence for expanding or reconsidering the definition of ACEs. So Finkelhor and his group have done a lot of work in this area, and I encourage people to read his studies that have done just what I'm suggesting, thinking theoretically and testing things empirically. So our question was, is spanking an adverse childhood experience? And again, wanting to know theoretically, does it make sense? And empirically, what does the data say? So a little bit of background about spanking. In North America, spanking is common and remains legal. So spanking has been defined as the use of physical force with the intention of causing a child to experience pain, but not injury, for the purpose of correcting or controlling the child's behavior. So we know that spanking is associated with the risk of more severe types of child maltreatment. So those are things that are currently on considered ACEs. We also know that numerous studies over the past 20 years have been shown that spanking is associated with mental disorders, suicidal ideation and attempts, and self-injurious behaviors. And we also know that studies have found that spanking, there's no study that find that spanking actually enhances child development. So we wanted to look at spanking with the other ACEs and how they relate to adult mental health impairment, and whether or not spanking empirically is similar to other ACEs and should be considered an adverse childhood experience. So interestingly, this study, with a number of authors listed there, and in collaboration with the CDC, so Melissa Merrick, Katie Ports, and Derek Ford from the CDC, who have access to the original ACEs data. What I was informed a number of years ago, that spanking was actually collected in that original ACEs data, in the original study from Felitti's group in the 1990s, but no one had ever used that variable in any of the published studies to date. So this was a really interesting opportunity to look at spanking with the original ACEs data, where this field really evolved from that one study. So we could actually go back and look at that with a collaboration with the CDC, because that's where that original data is housed. So they were able to analyze the data for us in partnership and to ask this important question. So we wanted to determine if spanking should be considered an ACE, and in order to do that, it's important to determine whether spanking adds to our understanding of the relationship between negative childhood experiences and adult mental health impairment. And we had two main objectives for our study. So we wanted to examine the grouping or factor structure of spanking with physical and emotional abuse. And we wanted to determine if spanking has both similar associations as physical and emotional abuse with poor mental health outcomes, and also does it account for additional variance? So is it still significant in models when we look at it with emotional and physical abuse? So as I mentioned, this is actually the original data from Felitti's group, and so our sample is those from wave 2, so the sample size is a little bit smaller, just over 8,000 individuals. Age range between 19 and 97 years old with a response rate of 65%. So this is the original data from California. We looked at spanking, physical abuse, and emotional abuse. So spanking was asked by individuals asking sometimes parents spank their children as a form of discipline, and while you were growing up during the first 18 years of your life, how often were you spanked? So we considered no to be someone who said never or once or twice. And the reason for that is sometimes people will spank a child and then decide, oh, that didn't feel right, I'm not going to do that again, and they actually don't spank the child again. So we didn't want to consider someone who's experienced spanking only 1 or 2 times as someone who had that experience on a regular basis. And then yes was a few times a year to weekly or more. So these were individuals where spanking was part of more of a routine method of discipline. And we also looked at physical abuse, so that looked at individuals who had been pushed, grabbed, shoved, slapped, or had something thrown at them, or someone who had been injured, or whether or not the physical force had left marks. Emotional abuse was defined as that they were sworn at, insulted, or put down, or that an adult acted in a way that made them afraid that they were going to be physically hurt. So again, this is all from the original ACEs data. Our adult mental health outcomes that we looked at were depressed affect. So that was asked in the past year, have you had 2 weeks or more during which you felt depressed or sad, blue, lost pleasure, and things that you usually cared about? Heavy to moderate drinking was a period in your life where you consumed 14 or more drinks if you're a male and 7 or more drinks if you were a female. Drug use, street drug use was just simply asking have you ever used street drugs, and suicide attempt was asking whether or not you had ever attempted to commit suicide. So these are the adult mental health measures that we used in our study. So for the methods, I won't spend too much time on this, but we can discuss it in the questions if people want more detail, or you can go to the original article. We used a confirmatory factor analysis to examine the empirical groupings of spanking with the ACEs items previously demonstrated to be indicators of a latent measure of emotional and physical abuse. So that was a study published by Derek Ford and others in 2014. So we wanted to look at whether or not, so what this basically does is empirically it determines whether or not there's similar underlying structures, or these experiences, if they're similar, they will hang together statistically and they will group together, and we'll see that with evidence of a good fit in the data. Then we also wanted to use a series of nested, sequential, adjusted logistic regression models to first look at whether or not spanking alone was associated with the 4 adult mental health outcomes. Then we wanted to look at whether or not physical and emotional abuse alone were associated with the 4 individual factors. And then we wanted to put spanking and physical and emotional abuse together in the same models to see if the associations remain significant for spanking, even if we also adjusted for physical and emotional abuse. So what that would mean is that physical, if that were true, then spanking is actually accounting for more of the variance in the models, or that the relationship is still important, independent of whether or not they had experienced physical or emotional abuse. So what we found was that spanking empirically was similar to physical and emotional abuse. So they loaded on the same factor, they grouped together, which is an indicator that they have similar underlying constructs, or that there's similarities in these experiences. So they did factor together. So it's empirical evidence that they go together. And when we looked at the spanking in relation to the 4 outcomes without considering whether or not they had experienced physical and emotional abuse, spanking was actually associated with an increased likelihood of all of those outcomes. And then we took spanking out of the models and just looked at physical and emotional abuse, and we found significant relationships there. And then we put spanking and emotional and physical abuse together in the models. And when we did that, we found that spanking was still significantly associated with suicide attempts, heavy drinking, and street drug use. So we did lose the effect of depression, but the other outcomes were independently related. So even above and beyond under the experience of physical abuse, spanking was adding more to our understanding of these outcomes. So with regard to effects, you can see the odds ratios there. So if an individual reported being experiencing spanking, they had a 1.37 times increased likelihood that they would have also attempted suicide, a 1.2 times increased odds that they have had heavy drinking, and a 1.32 times increased odds that they use street drugs. This is adjusting for the experiences of physical and emotional abuse. So we understand that if we include spanking in the models, we're actually learning more about these experiences, and we're finding very similar relationships to physical and emotional abuse. So the conclusions from the study was that, importantly, spanking did load empirically with physical and emotional abuse. So that does indicate that there's a similar underlying construct with these experiences. So with spanking, emotional abuse, and physical abuse. Also, spanking remained associated with increased odds of 3 of the mental health outcomes. So that was suicide attempt, heavy drinking, and street drug use, even after accounting for experiences of physical and emotional abuse. So when we take these 2 points together, what it shows is that spanking has shared variance with emotional and physical abuse, but it also accounts for additional and unique variance. So if we look at spanking with physical and emotional abuse, we have a better model. We understand more of what is accounting for those relationships with poor outcomes in adulthood. So therefore, including spanking and physical emotional abuse experiences together actually increases our understanding of adult mental health problems. So our main study conclusions, our overall large study conclusion was that spanking should be considered an adverse childhood experience, or an ACE, and addressed in efforts to prevent violence. So from that work, we have created an infographic, which is here. And this just describes very simply and in layman's terms the overall findings without really actually any numbers or data or even describing the methods there. But we can see here that spanking is harmful and should be considered an adverse childhood experience, or ACE. It's similar to emotional and physical abuse. And then in the other panel, we have adults who are spanked are more likely to use street drugs, drink alcohol, and attempt suicide. So our recommendation from this work, but also situating this study in the larger body of research, so not just this study alone, but how this fits with all of the previous research in the area of spanking, our recommendation is that spanking should be never used on children or teens of any age. So if you look down at the bottom there, there's the full citation to the article. And this is an infographic that actually has the hyperlink. So you can click that link if you have access to the infographic, and that will take you directly to the article. The article is open access, so you can also go to the Child Abuse and Neglect website and put the title in the article, or search my name, and this article will come up. You can download it for free, so I encourage people who want more details to go to the original article. And as you can see there, it's listed as the 2017 Article of the Year in Child Abuse and Neglect, so that is also on the website under the Article of the Year title as well. This infographic is free and available for people to download or use if it's helpful in your area of work in any way. And we've also translated it to French, so we have it available in French and English due to the many talents of the research assistants and associates that work for me. And we are hopefully in the future will also be able to translate this to Spanish. Those might be the only languages we have the ability to translate in our lab unless we have someone volunteer. So before I conclude and open it up to questions, I also just wanted to mention that I'm co-editing a book that will be published in the next several months, so it's probably at the end of 2019, with Dr. Gord Asmundson from the University of Regina. On adverse childhood experiences. So the book is looking at evidence to advance research, practice, policy, and prevention. So this is a listing of the chapters that will be in the book. You can see that it covers a wide area. So it does review the history of the field, talks about definitions, the current state of knowledge in terms of reviewing the literature to date. It talks about a really important issue of universal screening and the controversies and cautions related to screening for ACEs. Talks about methodological limitations, but it also gives us a public health perspective, a global perspective. Talks about prevention, neural development, resilience, trauma-informed care, and creating safe and stable environments for children and families. So it's really really rooted in the evidence of the field. It sort of will be a collection of the current state of knowledge and recommendations for, identifies the limitations in the ACEs field and makes recommendations for where this field should go. So I think it's quite a useful tool for policymakers, students, social workers, healthcare providers, any professionals working with children and families who experience trauma. So I'll leave it there, and I think that's about 45 minutes, so we can open that up for questions. Thank you.
So sorry about that. I was on mute. Thank you so much, Tracy, for sharing this information with us today. We do have a few questions from the audience. Since we have a global audience today, I was wondering if you could talk a little bit about the prevalence of different ACEs in different parts of the world, specifically about spanking.
Yeah, so spanking is actually highly prevalent all over the world. And in some places, I mean, we don't have a lot of good data over time, so we can't really talk about trends over time, especially from a global perspective. We don't really have it anywhere. But we have a lot of prevalence studies in many different places of the world. In North America, in previous data, we would have, as high as 90% of people indicating that they spanked their child. There's some evidence, although our data, like I say, is not great, that it is decreasing, but it still remains quite high and very high in certain groups. Globally, in some parts of the world, you may have as high as almost 100% of parents or families indicating that they use spanking or physical punishment on children. So globally, spanking is one of the most highly prevalent adverse childhood experience that a child will experience. We have a lot of work to do in that area.
Okay, thank you for that. Here's another question. How should ACEs be better used, in your opinion, in patient treatment and therapy?
So this is an excellent question. So I think that if you follow a lot of the mainstream work on ACEs, so things that are sort of more on the internet or outside of the academic field, you will hear this big push for universal ACEs screening. And on the surface, it sounds like a really good idea because we know for sure that ACEs are associated with many terrible outcomes, and that's not disputed. So we know that's the case. The problem is in a clinical setting, if we just universally screen for individuals, there are a number of issues that might happen. If we just use this ACEs tool and count up the number of ACEs, then it doesn't really give the clinician a lot of information, especially if we're just using your ACE score is 3. It doesn't provide what we need to know. Also, many people will experience ACEs and be fortunate and not really need intervention. So your score alone doesn't really tell a clinician a lot. The other problem is if we're asking in a clinical setting about ACEs, we need to make sure that we have people who are really well informed about how to ask these questions in an appropriate and sensitive way. We need to know that we're doing it in a way that's not putting an individual at further risk for violence. So, these might be things that they may be adults and talking about things in the past, but they might also still be children that you're asking for, or adolescents who asking these questions might actually put them at further risk. And if we don't have interventions that are available to the individuals, then the question might be, why are we screening for these things? So just to tell them that a score and not be able to provide further intervention. So in order to assess ACEs in a better way in a clinical setting, I think clinicians need to be trained in understanding how to do those interviews and to do them in a safe way, and to make sure that they are able to connect the individuals with the needed interventions specific to that individual's experience. So using a simple checklist is not, in my opinion, a very good method, and I don't think it's really going to benefit individuals.
Okay, thank you. Kind of along those lines, an attendee is asking if there are other tools that you recommend to assess and analyze this kind of data. I guess you've touched upon that. Is there anything else you want to say about that?
Yeah, so I mean, I guess there's whether or not they're asking about how other tools that are better to use in research is one thing, and then there's other tools clinically, if there's better ways to assess child maltreatment clinically. So those would be two separate questions. With regard to research, there are many longer tools that look specifically at child maltreatment. So there's no other tools that really look at all of the ACEs in any more detailed way than what's available. But if you're looking at child maltreatment, so the abuse and neglect items, there are many different measures. There are, of course, we know the CTQ, the conflict tactic scales, which were developed by Murray Strauss. They have been measured and validated. We also have the childhood trauma questionnaire. That one is a lot longer, so it's not as easy to administer, but it does give more detail. There's also the childhood violence, experience violence questionnaire, and that one has also been used a lot more in Canada. and has validity to those tools as well. But basically overall, so there's a large number of tools that have been used, but I think what's really important is that we're not just simply asking people, did this happen to you, yes or no, and that we do look more towards tools that look at the actual actions, so things like pushed, grabbed, shoved, and hit, rather than were you physically abused. And often looking at things that using more than one item to measure different constructs. And then the other thing to consider is how chronic was it? How severe was it? Perhaps what age did this start occurring? And so measures of how severe and how chronic they are probably have a huge impact on an individual's life. The more chronic, the more severe, the more likely, the stronger the effects on all these negative outcomes across the lifespan. And many tools, including the ACEs tools, don't really assess that. So I think tools that can further our understanding of how chronic and severe the violence is for an individual would be ideal.
Okay, great. So are there other adverse childhood experiences that you think should be included on the list, or other than spanking, are there other?
Yeah.
Yeah.
So this is a growing and evolving field. So as I mentioned, I would recommend starting with David Finkelhor's work. 2000, I believe, 13 and 15. He has 2 papers published, and that's a really good place to start because it really helps you to understand that when we think about adding ACEs, we need to think about it from a very thoughtful way, using theory and empirical evidence. So some of the things that his work has pointed to was looking at things like community violence, and that's also done on the ACEs IQ, the international questionnaire, and it has included some of that community violence. Things like violence between peers and siblings are something that David Finkelhor has looked at. Poverty is another one that has been questioned whether or not that should be considered an adverse childhood experience. So those are some of the ones. I've reviewed that literature in the ACEs book that will be forthcoming. So some people have suggested things like dating violence should be considered, death of a parent should be considered. So there's a large list of things that have sort of been put out there. Some of them have been tested empirically, and lots of them haven't. So our lab right now is looking at doing that. So doing an empirical data analysis of parents who have reported about their childhood experience, and we also have an adolescent sample who are currently reported about their experiences. And we're looking at thinking about adding things like parental gambling problems, poverty, looking at contact with child protective services, and also including spanking there. So trying to advance that field in a thoughtful way.
Okay, great. Here's a question about the age at which children are when you collect data. At what age does the data collected from youth, collected directly from youth, accurate?
So a lot of the ACEs studies are actually collecting data from adults who are retrospectively reporting about their childhood experiences. So that's quite common in the ACEs literature, and that was the original ACEs study too. So you're asking individuals who are 19 to 97, I believe, in that original data, and that's quite common. There's many issues with asking children. Some of them are that also asking some of these questions, you have reporting laws in place. So if you ask children about some of these adverse childhood experiences, we also need to make sure that children are safe and protected. And if we know that if through research these experiences are disclosed, then we need to be following the laws on reporting abuse. So that makes it also difficult to interview children, but some people are able to do that using different tools and measures and techniques. But the data shows that the validity and accuracy of asking about adverse childhood experiences, whether they're adults who have to then remember, or whether or not they are younger, is actually quite good. So it is thought to be considered a valid method for asking about these events.
Okay, great. We have one more question. I'm not sure if you can speak to this. This person is asking about exploring developmental assets of children and links to success or problems. And he's asking, has any research explored the linkages between those two? I'm not
So,
sure what, yeah.
right. Okay, so I'm not sure if he's asking between the links between ACEs and developmental outcomes and educational outcomes. Is that what it was? Educational, or
Yeah,
the link?
he just says developmental assets of children and links
Okay.
to success or problems.
Okay, so whether or not, okay, so developmental assets. So whether or not that may be like almost like a resilience factor and leading to better outcomes. Is that maybe what the question's asking?
Yeah, maybe.
Okay, so there is a, as I mentioned, now sometimes when you do these ACEs scores, sometimes people also fill out a resilience score. So not everyone who, fortunately, not everyone who experiences ACEs or child maltreatment will have negative outcomes across the lifespan, but it does increase the likelihood that these things may happen. And part of, as a researcher, and I do work in this area as well, is trying to understand what is it about the people that experience these terrible things as children, but still do quite well? What makes them different? What was it in their lives that might lead to better outcomes? So we've been doing a lot of work in the area of resilience, looking at individual factors. So that, and a lot of work has been done on individual factors. So looking at individuals' personalities, um, for example, looking at things within their family, or looking at other relationships or community, looking at school outcomes, to see whether or not what it is in those in that child's life that's related to better outcomes. So some of the things that we've found is that self-esteem is a really important one, and having a good outlook on life. So being hopeful for the future. Other research has looked at that. We've looked at things like physical activity is related to better outcomes for these individuals. So we're also relationships, looking at relationships with non-abusing the non-abusing parent, for example, or relationships with other individuals, such as an aunt or a grandparent, or even a teacher or a coach, and if you have a positive relationship with others. So trying to look at different aspects in one's life leading to better outcomes, and we are finding that there is some clues there which may help to inform intervention strategies.
Okay, great. That sounds like a very interesting work. That's about all the time we have for questions today. So thank you, everyone, for your questions, and again to Dr. Fifi for being with us today. I'd like to let everyone know that a recording of this webinar and a PDF version of the slides will be available within 24 hours on our website. We encourage you to become a member of ISPCAN so that we can continue having informational webinars like these in the future. And if you are interested in presenting yourself or have ideas for topics for our webinar series, please contact us at resources@ispcan.org. Thank you all again for your time today, and we hope you have a good day or night, depending on where you are. Thank you, and bye-bye.